Okay, so I'm a little confused here then. So our government has not declared a public health emergency that relates to fentanyl. Yet next door in British Columbia, the emergency has been declared. The data that's been collected at different regions, different medical resource centers is being shared collectively. This seems like a pretty strong and simple approach to really gather what you need to even begin to formulate a plan. Why is it then, in your opinion, David, that our government is hesitant to call this public health emergency?
I think you'd have to ask them that.
Yeah, sure.
They have some arguments for not calling it, but the bottom line is, are we organizing our resources effectively? Are we getting the information we need to be effective and measure how we're doing over time? Certainly in BC, where they report the numbers and the characteristics of these folks every 2 weeks, and progress or lack of progress in certain parts of the province, there's a stronger sense that we're all working together, we know what we're dealing with, and we're either winning or losing in some areas, and how we may have to change our approach. We need more of that leadership in Alberta.
Clearly. Kerri, what is working? Under the current Alberta Health Services, I guess, plan of attack, from your vantage point, what are we doing that is actually working?
In terms of fentanyl specifically?
Treatment, anything we can do that's had positive results that can be expanded upon under the current system?
Well, I think having the rescue kits is good.
Huge, yeah.
I mean, that's a very sort of tertiary approach because it's a rescue approach.
Yeah.
But trying to get the word out more with that would be good, that those are available.
Education, yeah, certainly.
I'm not sure where they're at with treatment programs, but there's always new sort of creative grassroots treatments programs coming about. It'd be nice to see some more of those, and AHS funding going towards some of those.
Yeah.
And connecting them with housing and basic stabilization to make people actually get off.
This is a big part of the problem, of course.
Yeah. The addiction is not just the drug. It's so complex and so systemic that it's...
Some of the complexities have to do with mental health issues, right? I think, well, you'll know better than me, stats will probably show it as well, that most drug addicts, fentanyl addicts, are going to have mental health issues as well, severe in some cases. How tough is that for physicians to sort of pinpoint, well, what is the true issue here? Is it the mental health issue that's feeding from the addiction, or is it vice versa?
So that's often a really complicated problem, and so often we, as family doctors, some of us have more experience in that area than others, and some offices have extra support, psychologists, social workers, but some primary care doctors don't have those supports. So often we'll want to refer into Alberta Health Services, such as Access Mental Health. It's sort of a centralized referral service for mental health services in Calgary.
Okay.
But currently, I was just notified that there's a 14-week processing gap where the referral goes in and it's 14 weeks before it's even triaged.
So we're talking about somebody who is an addict or a mental health patient?
Any mental health issue that you're referring for, or anxiety, depression, addiction, schizophrenia. Yeah, so that was a bit shocking.
That's a bit concerning.
Frustrating. Yeah, it's a bit frustrating because that's even, then they're triaged and then they're on the regular wait list, from my understanding.
And how long is the duration usually you're going to sit on the regular wait list for?
So that's usually in order of weeks to months.
Weeks to months.
Yeah, depending on which service you're looking for.
Look, I'm not trying to slag on Alberta Health Services.
Yeah.
That's not my goal here.
Yeah.
But
well, I'm bringing it up as
no, and I know
to
these
be
are
aware
facts.
that
Absolutely,
this is a problem
absolutely.
that we'd like to see.
I mean, it's hard. I mean, people want to point a finger, and frankly, it sounds like really not enough is getting done. Now, Alberta Health Services has stated with regards to the public health emergency declaration, the reason why, or I guess part of the reason why they don't want to make that declaration is because they say that it would give the province extraordinary powers, such as the ability to enter people's homes without a warrant, or to declare a quarantine area. Do you buy that whatsoever? Is that just silly?
Well, that's generally the common approach to infectious diseases. Where you might have to intervene and stop some kind of infectious chain. In the case of this kind of an outbreak, it's not relevant.
No.
What's really relevant is that we need to know the information on a timely basis. We need to work together all across these various sectors: human services, education, policing, health. We need to communicate better. We need to know that we're all on the same plan and program. And we're all learning the same things every couple of weeks. We know what we're doing and how we're progressing or not. And that's the essence, I think, of what is needed for leadership in the province. The mental health report submitted back in December outlined many of these characteristics of a mental health system that's really working and responding in a timely way and working together in an integrated way. Unfortunately, mental health and addictions is grossly underfunded, has been for decades. Across the country, it's the same. There needs to be a much stronger commitment to addressing early intervention on these folks' families, children at risk, early intervention in people going into prison or jail for the first time. There are tremendous opportunities for prevention and early intervention if we stop punishing and start rehabilitating some of these kids and some of these young adults that are getting into trouble.
You mentioned young adults. Kerri, is that predominantly who you're treating, or is it kind of across the board? I mean, who is the average fentanyl user that you're speaking with, if there is such a thing?
Yeah, so in my experience, it's been young adults to middle-aged clients. But if you look at the Alberta statistics, they're reporting deaths from age 10 to 84.
Yeah, huge gap.
Yeah, so it's a huge demographic.
It's a big scope, yeah.
Yeah.
And of course, it makes it difficult then. I mean, I guess again, more to your point, David, without that data involved. I mean, sure, we've got age groups, really, and I think we might have gender, but that's all we know. So as far as socioeconomic status, how is the plan supposed to be built when, we can't target kind of that at-risk demographic? Is it possible?
Oh, I think it is definitely possible. We have the numbers, we're just not producing them and analyzing them and making them available.
So with the data, of course, it's possible. As it stands now, like a real, plan of attack.
Yes.
It's tough to formulate.
Part of the challenge has been Alberta Justice, which deals with the deaths, is not able, it seems, financially to produce the data in a timely way and send it over to Alberta Health, which can then make it known to at least the health system, but preferably to all Albertans. There's no reason to hide this data.
No, I don't understand.
It's not going to create panic to know what age groups, and we know the younger folks are in real danger. The recreational user is the real one in danger in this.
It's clearly not just an issue of money, though. I think you probably both would agree with that. It's a huge part of the issue as far as trying to solve what's going on here. Physicians, do we have enough physicians that are involved in this sort of treatment? And if not, how do we get more people involved?
It's going to take more resources, more incentives, and a stronger commitment, I guess, to harm reduction therapy. So making more available Suboxone, it's free, but not enough physicians or nurse practitioners or mental health workers, pharmacists are being empowered to use it and to supervise that complex treatment that is needed. It needs to be supervised every day.
When a physician in solo practice or community practice doesn't necessarily have all the tools and supports, because rarely would you have a physician just giving a patient something without having the team. And so not a lot of physicians work in that environment. So it makes it a lot more challenging.
Yeah, certainly.
And you have to have a special license for methadone and Suboxone. You have to do a special course and apply to be able to prescribe. So there's reasons for that are legitimate. But so there's just lots of reasons why there's not a lot of physicians doing it. But I think there's the stigma, and they're challenging clients in so many ways as well. So incentives for physicians to do that in other environments might be helpful.
I think crime and punishment is probably on the mind of many of the viewers tonight. We've seen the numbers, we talked about the numbers earlier, people are dying. Those that are peddling fentanyl, knowingly cutting their drugs with fentanyl, David, are you in support of mandatory minimum sentences for some of these people?
I'm not sure. I'm still weighing the benefits and costs. Many of these people are sick themselves, addicted in some cases. Many of them have been traumatized so repeatedly that they don't really understand the implications of what they're doing. So my emphasis has always been on rehabilitation. And yes, that may include mandatory incarceration, but it has to be associated with mental health therapy and rehabilitation.
It is a big issue, isn't it? I want to talk a little bit about safe supervised injection sites. There's a movement now in Calgary to, and this surprised me, to actually, I guess, finally build or supervise Alberta's first safe injection site. They've had them in BC for some time now. Tell me a little bit more about this. I know you're involved with this, David.
Yeah, well, both federal and provincial governments have been conservative in the past many years, and they have not supported harm reduction. We now got governments both in Ottawa and here in Alberta that see the benefits of harm reduction, and we're seeing a movement among various groups and non-government organizations and some medical students at the U of C that are pushing this agenda.
Students, that's awesome.
Yeah. Yeah, and it's remarkable what they're trying to coordinate with Alberta Health to get this first safe injection site going in Calgary.
And of course, this doesn't just relate to fentanyl alone. We're talking a broader scope. Curb the spread of infectious disease and whatnot. Kerri, you're on board with this as well?
Yeah, definitely. Having a safer site that's a controlled environment for controlling the drugs that are used, the infectious diseases, but it also provides an environment where you can help clients and get at their other lining issues, work on housing and stabilization in a safe environment. So you're not just dealing with the actual drug you're injecting.
Finally, carfentanil. So carfentanil has just reared its ugly head in Alberta. This is a substance, well, they're saying 100 times more potent than fentanyl. It's an elephant tranquilizer. How terrified is our medical community learning that this drug is now on the streets of Alberta?
Well, we should all be terrified, I think, rightly so, that if 1 or 2 grains of fentanyl is lethal for some people, how do we deal with something that is so profoundly lethal? But it points to the same issues. Early intervention in high-risk kids and families, get the supports around people who are addicted or in early stages of recreational drug use, get more rehab programs and harm reduction programs, extend the resources and use the resources we have more effectively together. And to
cohesively
do that,
is the key.
cohesive, integrated, and ensure that we, I guess, in the same sense, have the data and the analysis to tell us how we're doing. Are we moving
seriously,
in the directions?
Right?
We need to know how it's going.
I'm going to make that our final word. I want to thank you both very much for taking the time and joining me tonight.
Glad to be here.
Folks, that's all the time we've got. As per usual, you can get at us on Facebook. We're on Twitter. Don't be a stranger if you've got a show topic idea, complaint, or a compliment. Till next time, take care.